Look comfy this morning, Kamryn. Sleeping away like a little comfy girl. Look at that.
I had her on her back and she woke up too, so she actually just got all finagled back to bed. There you go. Now listen. Listen, you're making it sound like we're killing you. Yeah. Let's put this back on
Look, her hair doesn't look like Mia's.
Yeah. You had hair like your big sister. Thank you.
Yeah, you want to see Mama and Daddy? They can be here and see you.
She's staring at her sister and brother.
Yeah.
She's doing fine.
No poops for her yet?
Nope. Nope.
Neither one of them?
Nope.
Come on, girls.
Holding on.
Come on, girls. You going back to sleep now, Morgan?
I'll reach in and say hi.
Huh?
I'm going to just reach in.
Mommy's gonna reach in and say hi.
Hi, baby. Hi.
She knows that's the mommy.
Hi.
You're absolutely beautiful.
Thank you. Do you want me to finish her diaper, or?
Yeah, I can do that. I just, so both of them, the little IVs in their hands.
Yeah.
So the deck man is doing. Sleeping away. Hey buddy, you hear us? You hanging out in there?
Honestly, it makes no difference. I don't know if anybody...
Did you have a good night? What's this, day 4 of your life? Cute little man. Oh, stretch it out. Stretch it out. Oh. He got himself all comfy.
But, you know, now that she has her pick line, she's all set. She's okay having his UV, but he probably will eventually need a pick line. I would bet.
Yeah.
So. How is it? It's getting your diaper changed. Yeah.
Dr. McDonald, I'm one of the pediatricians. I was at your delivery.
Oh, hey.
I remember you.
I started out at A, and then I ended up at C.
Yeah.
Jumping over all the
All
the tubing in there.
Yeah,
That was a crowded room.
It was. It was impressive.
But they all did great. So
Yeah.
I'm here today. I'm usually down here in
Okay.
the NICU on the weekends and nights and stuff. But I don't know if you've had a chance to talk to Dr. Catlin lately about how they're doing.
Not since
and
yesterday,
so
yeah.
So they're all doing fine, respiratory-wise, breathing and so forth has been good and stable. Feedings they didn't tolerate.
Right.
Well, she tolerated better than the other two.
Right. Okay.
But Maureen noticed a murmur in Kamryn.
Yes. Yeah.
This morning, and we all listened to it, and we're pretty confident that it's perfectly consistent with a called a patent ductus arteriosus, which is a normal physiologic thing that happens with fetuses. So you have your fetus, you're supposed to have basically a bypass of your lungs, because you don't need your blood to go to your lungs.
Okay.
When you're fetus, and when you're born, if you're full term, that's going to close on its own. When you're preterm, it doesn't always close on its own. And the more preterm you are, the less likely it is to close on its own.
Okay.
So basically every 24-weeker is going to have this valve stay open.
Okay.
And what that will, and then in the in-between areas may or may not have it. And so we're pretty convinced based on murmurs that these two have it.
Both of them?
Both of them. And so what that means is that not all the blood that's coming out of the heart is going to the body.
Okay.
Some of it's back flowing to the lungs, and that's why we hear them murmur.
Okay.
And when that happens, their lungs can get wet, their respiratory disease can get worse. The places that need the blood, like the gut and the kidneys and all the important things, don't get as much because some of the outflow is going kind of like going backwards towards the lungs. So At this gestational age, this degree of prematurity, it's very unlikely that it will just close on its own.
Yeah.
So we need to do something. So what we do first line is treat with medication called indomethacin, which is very similar to aspirin or ibuprofen. It's an IV drug, and what it does, it's a prostaglandin type drug, is it squeezes the vessels.
Okay.
And probably at their gestational age, there's more than 50% chance that it will work.
Okay.
It's a pretty safe drug. Sometimes the babies don't do well with it, and in a way that's a good thing, because we know that the blood vessels are, this is supposed to squeeze vessels, and if this squeezes the duct that we want it to squeeze, then sometimes we see that in the urine output too, and that's transient, and that will go away.
Okay.
So in a way that's a downside. We don't want the urine to go completely away, but at the same time it tells us that our medication is working.
Okay.
So we'll follow urine output closely. Very, very rarely there can be bad complications with the gut.
Okay.
And that's perforation of the gut, and it's extremely rare, but I need to tell you about it.
Okay.
The flip side is that if we don't treat, we don't have good blood flow to the gut, and we don't tolerate our feeds, and we never tolerate our feeds, and we never grow. So, so it's kind of, we're kind of stuck. It is our treatment. It's what we do. And then if we give a couple doses.
Okay.
We stop feeding during the treatment. We give doses 12 hours apart. We follow the urine output. We check labs. We follow urine renal function. We follow the platelets. It can have some platelet inhibitory stuff, but it doesn't really affect any of our babies.
Okay.
Very rare platelet complications. And then we go from there, and in 3 doses, 12 hours apart, the MurMur's gone. We presume that it's closed, and we start feeding again.
Okay.
If the MurMur stays, then we'll get our cardiologist involved and decide about next step.
Okay.
Next step would be either potentially continuing the dose or going to a plan B.
Okay.
Which I'm not going to tell you about, because I think plan A is going to fix it.
Okay. So when would we start?
We would start as soon as the
10 a.m.
Okay.
We started.
Oh, all right. Well, then it came up
That's
already.
the time. Yep.
Okay.